thought I'd give you a little bit of a snapshot about what uveitis in Alabama is like. So for my disclosures, I've received consulting fees from these companies which have nothing to do with what I'm going to talk to you about, and I've received research funding from a variety of entities in the past, part of which has funded this study. So again, the goal here is to give you a snapshot of what the types and referral patterns of uveitis are like in the catchment area of the UAB uveitis service. Basically, these are the patients that most of you are sending me, which I greatly appreciate. And as you may or may not know, one of my interests is ethnic disparities, ethnic variations in uveitis, not only in presentation but outcomes. I'm not going to talk a lot about that, but I am going to focus some on some of the ethnic variations in patients and hopefully show you some interesting data that might be interesting to look at in the future. So, I don't think anybody's unaware of this, but to remind you, uveitis is by definition an inflammation of the uveal tract. In practical use, we expand that term to include things like scleritis and retinal vasculitis, and as you saw in Dr. Ye's lecture, retinitis. Those technically wouldn't be uveitis since that's not the uveal tract, but they all fall under that umbrella, and so we'll include those in this as well. It is not a disease. It is a collection of disease. There's hundreds of different possible conditions, both systemic associated conditions, well-defined ocular syndromes, which still, honestly, technically could be defined as idiopathic, but which we separate out from idiopathic disease. In general, it's thought that about 90% are autoimmune in nature, 10% infectious, and less than 1% a combination of neoplastic conditions like lymphoma, like we heard earlier, drug-induced disease, and trauma. So the uveitis person can classify uveitis in a variety of ways. Temporal, is this acute versus chronic? Laterality, so is it one eye, both eyes? The inflammatory pattern, meaning granulomatous, non-granulomatous, but the main way we do this is anatomically still. Where in the eye is the main site of the inflammation? So that can be anterior inflammation where the iris and the ciliary body are involved, therefore called an iridocyclitis. It could be an intermediate uveitis where it seems that no specific structure in the anterior of the eye is involved, but there's predominantly vitreous cell with very little, if any, anterior inflammation, but there shouldn't be any lesions of the posterior uveal tract. If you have chorioretinal lesions, then by definition, that should be called a posterior uveitis. And if you have inflammation both in the front and the back of the eye, then we term that a pan-uveitis, or some people call that diffuse uveitis. So the burden of disease, uveitis, depending on which study you look at, is responsible for anywhere between 5 and 20% of the legal blindness in this country. If you think about the epidemiology of it, there's not a lot of people that have uveitis. The best data we have comes from Northern California. Dave Greitz and Ira Wong did a study out of the Kaiser Permanente HMO in Northern California, so a captive population of a lot of patients from which they could pull out, and they actually had EHR for a long time before a lot of us, pretty good quality data. And there's about 52 new cases of uveitis per 100,000 people per year in that population, a prevalence of about 115 cases per 100,000 at any one time, which means about 1 in 870 people, or about 360,000 persons at any one time in the US has uveitis. But yet, with that small number of people, up to 20% of the blindness in this country is responsible for this. So there's a huge burden of disease, both from anterior disease, as HLA-B27, you can see on the top, and things like serpiginous, different forms of posterior uveitis, like you can see on the bottom. So, sort of give you this Birmingham or Alabama baseline, I thought it'd be interesting so you could see what it's like in our neck of the woods. So this is based on data that's been collected over a number of years. This primarily is from a retrospective chart review of patients that I saw between 2007 and 10, inclusive of those years on the uveitis service here. So if we focus mostly on that anatomical distribution, anterior, intermediate, posterior, and pan-uveitis, this is our population. Over that time period, we had 781 unique patients present to the uveitis service. Of those, 72% had anterior disease, 10% intermediate, 11 posterior, and 13 pan-uveitis. So that's interesting. What's more interesting is to put that in the context of, is this different than other parts of the country? And there are a number of population studies primarily based out of uveitis clinics. So anytime you look at a population of patients of a disease that's not that common and you look at a tertiary referral center, then there's a real problem with referral bias, right? So you have a funneling effect. So if we took any one person's clinic, you might not have a lot of patients, but if you refer those in, and usually it's the more severe cases that are referred in, and you just look at the patients in that referral center, then you're going to tend to see the worst cases. And a lot of times those are the more posterior cases. So if we look at other studies, so Duke has had a longstanding uveitis clinic. It's also in the southeast, east coast, eastern seaboard, southeast. They looked at their patients, and you can see the distribution here was actually quite a bit different. So they only had 25% of their patients were anterior, 12% intermediate, about 24%, so equal to anterior, were posterior, and almost 40% were panuveitis. So it's important to look at the context of this. The Duke, the Duke clinic, Glenn Jaffe is a retina-trained specialist who also does uveitis. So the referral bias, again, funnels in where most of the patients he's going to be referred are posterior involving disease. Well, that's fine and interesting, but if you were going to try to do research studies out of such a clinic, you're going to have a biased population towards the kind of patients that were referred to him. Well, why does that matter? Well, if we look at what's out there in the community, so there was a really interesting study done in Southern California, actually well over a decade ago, by Colin McCannell, Gary Holland at UCLA. So they did a comparative study where they simultaneously, prospectively queried a consortium of general ophthalmologists in the Southern California area and Dr. Holland's uveitis practice at Jules Stein, UCLA. And they collected 213 patients from each population and compared. So I've not put in the uveitis referral center group. I've only pulled out the private practice, because this was a consortium of private practice data. So you can see what we think, and again, the data is not perfect, but this is probably the best data we have, that in the general practice of ophthalmology, about 90% of uveitis that's seen is anterior. Well, that's what we all seem to know intuitively, right? Only 1.4% was intermediate, 1.4% pan, and about almost 5% was posterior uveitis. So if that's representative of what's out there in the real world, then again, if we were going to leverage off of a clinic that had a large population of uveitis patients for epidemiologic studies, or again, as I'm interested in ethnic disparities, you would want that referral center population to as closely match what's out in the real world so you could extrapolate that data to your practices if possible. So I would argue that in Birmingham, we actually have some opportunities here because even though it's not an exact mirror, it is pretty close and closer than other uveitis centers to what is out in the general world. So if we break it down further, so this is just the Birmingham population. Again, 781 patients. You know, the population of Alabama around the time that we gathered this data was 4.7 million. The mean age of patients in our study was 46.5. 2/3 were female, 1/3 were male, which fits with what we know about most autoimmune diseases. And again, if we break this down by ethnicity, are there differences? So 42% of the patients seen in the uveitis clinic were African American, 55% were Caucasian. There was actually a small number that were other ethnicities, about 3%. Now, not all of these patients, and I'll show you some geographic data in a minute, not all of these patients came from Alabama. So you have to take some of this I'm going to talk about with a grain of salt, but the population distribution of ethnicity in Alabama is not too dissimilar from Mississippi, the panhandle of Florida, et cetera, which is really where our catchment area is. 25% of the residents of Alabama are African American, 70% are Caucasian. So you can see the difference. If 42% of the patients who had uveitis in the clinic were African American, well, that's a significant overrepresentation. And there is some data that uveitis is more common in African Americans than it is in Caucasians, which this would fit. Really no difference in the mean age of those patients. There was a difference in the gender distribution where you can see that African Americans were even more likely to be female than were Caucasians. So if we go back to that anatomical distribution, so again, in our total population, about 70% anterior, African Americans were almost the same, 70% as were Caucasians, so no real difference. So ethnicity didn't really seem to impact that anterior uveitis was the most common form. Intermediate, similarly, not a lot of difference, between 9 and 10%. But if you look at the posterior and panuveitic disease, there's pretty significant differences. So African Americans, 5% of their disease was posterior, whereas 16% of the Caucasians' disease was posterior. And almost the entirety of that difference was accounted for by birdshot. So birdshot chorioretinopathy, as far as I know, and Steve, correct me if I'm wrong, I don't know that it's ever been reported in an African American. I've certainly never seen it in one. I've seen it in Hispanics, I've certainly seen it in Caucasians, but if so, if it's there, it's very, very uncommon. And so much more common in Caucasians, and so the big difference there is in Caucasians with birdshot. Pan-uveitis, about 20% of the African American disease was pan-uveitic, whereas only 7% of the Caucasian disease, which again was a difference between those two. And a lot of that was accounted for by idiopathic disease because most of the pan-uveitis was idiopathic in nature. Not as much as is accounted for by sarcoid as you would think. And there's my graphic I forgot to click forward on. There you go. All right, if we look down at etiology now, this has taken all anatomical categories together. So despite the fact that you sent these patients in to the tertiary referral center, and I did a, quote, standard or appropriate uveitis workup, still 50% of all patients are idiopathic. No matter how many tests I do, no matter how much we look, we can't find an etiology for their disease. What I tell patients is, as long as we know it's not infectious, that doesn't matter, because really we don't have targeted treatments for certain diseases that are autoimmune versus others that are autoimmune. The disease is the same, or the treatment rather is the same. You suppress the immune system, but still, it's important that we look. And you can see, though, that even though the differences weren't that great, it was statistically significant that African Americans were more likely to have idiopathic disease than were Caucasians. B27, not surprisingly, was much more common in Caucasians, although there are a significant percentage of African Americans that do have that. And, data I'm not going to show you, African Americans who do have HLA-B27-associated acute recurrent anterior uveitis tend to have much worse disease than do Caucasians. There's a whole other talk I can give you about disparities in severity and outcome of disease. Sarcoid, not surprisingly, was more common in African Americans. Persistent postoperative disease, this is right on the verge of statistical significance, but you can see that African Americans are more likely to have persistent post-op disease, and this is mostly post-cataract surgery, although there are some post-TRAB patients in here as well. Herpes Zoster, there was a difference with African Americans having that, or excuse me, Caucasians having more of 4% versus 0.3%, which that graphic's a little confusing. Ankylosing spondylitis, again, that fits in with B27, but those are patients who the B27 wasn't checked, but they had diagnosed ankylosing spondylitis. And as I already mentioned, birdshot, no African Americans, and about 4% of patients I had birdshot in the Caucasian, that were Caucasian. Juvenile arthritis, Caucasians were more likely to have that. Toxo, really no statistical difference despite the doubling of the number there. VKH, again, statistically significant with slightly more in, actually in African Americans at 2% versus 0.5%. And you can see the others becoming less and less frequent. So if we look at, just break this down into infectious and non-infectious, because it's sort of interesting, like I mentioned, as long as we know that a uveitic disease is non-infectious, then our treatment doesn't change. But so infection, it's very important to know if it's infectious, one, and if it is, what exactly the infection is, because the different treatments vary based on the infection, right? One antimicrobial doesn't treat all infections. So we had 80 infectious uveitis cases. There was no difference in the mean age between those groups. There was a difference in the distribution of gender between those, with males being more likely to have infectious disease than females, which had more non-infectious disease. And if you look at the ethnic distribution, then actually Caucasians were much more likely to have infectious disease than were African Americans, and the predominance of that was in viral anterior uveitis, so either zoster or simplex. And so again, highlighting some of these, African Americans versus Caucasians. Now some of these are a mixture between different forms of zoster, whether it's anterior or posterior disease. You can see in syphilis, there was a difference with African Americans more likely to have syphilitic uveitis, not to a statistically significant degree, but approaching there. Lyme disease, which, as I teach our residents, Lyme is not very common, but we do have a few cases here in Alabama. suppose the Alabama Department of Health has recently declared Alabama an endemic area because we had like 2 confirmed cases in a certain period of time. It's a pretty low bar. HTLV is a virus it's endemic. It's not my choice. Is endemic in Japan, but also in the Caribbean. And so, since a lot of people from the southeast take cruises down to the Caribbean, it's not uncommon. That occurs, in my experience in this clinic, predominantly as a co-infection with HIV. That's human T lymphotropic virus, which can cause a certain form of T-cell lymphoma. But it can also cause a posterior uveitis retinal vasculitis type picture. So, moving on from the etiologic and anatomic distribution, I wanted to show you some geographic data, which I found quite interesting. So again, this is a retrospective review of our clinic, a little different time period. We pulled out demographics, the disease characteristics, and then we took zip code data of those patients to their home of record, de-identified everything, and then used an online tool, which is Google Fusion Tables, and this service called Batch Geo to construct geographic representations of the distributions. So if you can see, Birmingham is here at the center of this hotspot, not surprisingly. Here's Atlanta over here where Steve is, Dothan, Mobile. So obviously most of the patients that we've seen here come from the Birmingham and greater area. Really, if you follow the interstate pattern, you can tell where patients come from. We have a few little pockets. There's some that come from Jackson, quite a few from Dothan, the Panhandle, actually a few from Atlanta. So sorry, Steve, but I'm sure your heat map is much larger than that and includes Birmingham as well within it. But you can see where the catchment area of patients we've seen is. So I know this is a little difficult to see. I tried to make it as easy as possible. It's hard to show the whole geographic region without cutting something off. So this is patients from each zip code with color-coded by anatomic categories. So if you see down here, red is anterior uveitis, yellow is this category called anterior and intermediate. That means it's not panuveitis because they had no posterior segment involvement, but they had enough in the vitreous to make us think it was more than anterior. That's an official Sun standardization of uveitis nomenclature category. Purple's intermediate, green posterior, and blue pan. So if you look around, you can see that the anatomical category varies a good bit by zip code. So there's a lot of anterior disease in the area right around Birmingham and sort of north, but then it peters off, and there's less anterior disease referred in from the more outlying regions, except maybe for down in the Dothan area and in Montgomery, which I think is kind of interesting. So patients living closer to the study area had more anterior disease, and individuals more distant had non-anterior disease. That makes some sense. I mean, we generally think of posterior panuveitic disease as more severe, so maybe those patients are more likely to be referred, right? It's probably, again, just a function of referral bias. If we look at ethnicity, so in this, red represents African Americans, yellow Asian, purple mixed race, green Latino, and blue Caucasian. So interesting, you can see that within the region immediately surrounding here, including Birmingham, African Americans made up a significant proportion, but the farther away you go, the less, with a few little pockets of exception, African Americans, which again are red, make up less of a percentage of the patients referred from that area. So my personal theory of that is that there could be a lot of reasons, but one of those could be access to travel and willingness to travel to sort of the big city, to Birmingham, to be seen, which could go to socioeconomic status, ability to access resources, which goes to healthcare access, and is a huge problem in a state like Alabama, where we have a lot of very poor people who live in rural areas. So those that are able to travel can come in. Those that live locally to the center may have better access to care. This is gender. There's really no difference in the gender of patients referred in from the different areas around the state. And this is diagnoses. And there's a lot of these, and it's really hard to say, but you can see that red is idiopathic, and that makes up the majority, as I mentioned in the other slide, of all the patients referred into the center here in Birmingham. And the others, there's really no clear pattern that I could delineate from the pattern there. And just to look a little closer, here we are zoned in on the Birmingham area. You can see that the majority, or at least half, of patients in the Birmingham area were idiopathic, and it made up the majority, in most cases, of the diagnoses in other areas. So in summary, the prevalence here in Alabama, if you do the math based on this, and again, big grain of salt because there's more than just Alabama residents here. If you take the population of Alabama, that was about 16 per 100,000 people. There's no way we're capturing all those patients. So that's not at all a true representation of the prevalence of uveitis in Alabama. The UAB population is more in line, as I mentioned, with the frequency of uveitis of the various anatomic categories. In the general population, African Americans are overrepresented in this population compared to Alabama's general population, again suggesting that there is an overburden of that disease in the African American population. And their referral in is skewed by the geographic location, as I mentioned, suggesting that perhaps they have less ability or are less likely to travel to a center for care, and etiology did not vary by geographic location.